Good day. I am Alexa Cabrera, and for this crash course, we will be reviewing fetal cardiovascular physiology. So, in this reviewer, our objectives are to understand cardiac embryology and its development, to differentiate between adult and fetal circulation, to trace the course of fetal circulation, to review the anatomy of the placenta, its variations and functions, and to discuss the congenital anomalies and its implications. So, we will begin with embryology. We have a progress bar on top so that you can see your progress through this review. So, the CV system is mainly derived from the mesoderm. It's formed during the 3rd to the 8th week age of gestation. By the 5th week, you have a heartbeat that can be heard and a fetal heart that can be seen. And by the 8th week, you already have a fully functional heart. However, development continues until outside the womb. So, the heart originates from the lateral splanchnic mesoderm, which has a cardiogenic field or a cardiogenic area. So cells from this area will develop into two tubes that will then fuse, and this establishes a tube with a bifurcated arterial and venous end. The heart will then fold and rotate, and the most important thing that you have to remember is that the ventricle moves ventrally and to the right, and the atrium moves dorsally and to the left. So, of course, the blood vessels also have to develop, and they do this through two processes, either through vasculogenesis or angiogenesis. So, vasculogenesis is the formation of blood vessels from angioblasts, and these angioblasts then coalesce to form angiogenic clusters. The clusters form angiogenic cords, which will become your vessels. And you have your angiogenesis, which is the formation of new vessels by branching from existing vessels. So if this is your angioblast, they coalesce and then they eventually form your vessels. That's vasculogenesis. And then angiogenesis are vessels that already come from existing vessels. So this is quite an important slide. To remember the embryonic structures, I've attached the photo here. You have your truncus arteriosus, your bulbus cordis, your primitive ventricle, and your primitive atrium, and then your sinus venosus at the bottom. So remembering this from top to bottom can help you remember what they give rise to, because it also goes mainly from top to bottom. So like your truncus arteriosus, it will give rise to your ascending aorta and your pulmonary trunk. Your bulbus cordis gives rise to the smooth parts of both your right ventricle and left ventricle. You have your endocardial cushion, which gives rise to all of your valves, your interventricular septum, and your atrial septum. Your primitive atrium will give rise to the trabeculated parts of your right and left atrium. The primitive ventricle will give rise to the trabeculated parts of your right and left ventricle. Your primitive pulmonary vein will give rise to the smooth parts of your left atrium. And the sinus venosus right here has a left horn and a right horn, the left horn giving rise to the coronary sinus, and the right horn giving rise to the smooth parts of your RA or your sinus venarum. So lastly, your superior vena cava will come from your right common cardinal vein and your right anterior cardinal vein. So that's it for embryology. We're now moving into fetal circulation. But before I discuss fetal circulation, let's go back to adult circulation real quickly. So you have your superior vena cava and your inferior vena cava drains into your right atrium, and then they drain into your right ventricle, going into your pulmonary trunk to be oxygenated in your lungs. So your pulmonary veins already carrying oxygenated blood will then go to your left atrium, left ventricle, your aorta to be pumped through your systemic circulation. So your fetal circulation is much the same with a little bit more additions. So you have special features such as vessels and shunts. So you've added your umbilical vein here, your umbilical arteries, because there are two, as opposed to your umbilical vein, which only has one. Your shunts, which are your ductus venosus, your foramen ovale, and your ductus arteriosus. So we will be discussing these vessels and shunts. So first are your vessels. You have two umbilical arteries and one umbilical vein, as mentioned before. Your arteries will carry deoxygenated blood from the baby to your placenta, while your vein will carry oxygenated blood. Note the color in the drawing, it's red. Will carry oxygenated blood and nutrients from your placenta to your fetal heart. Now, your shunts, why do you need shunts in the first place, and why don't they persist in adult life? So your shunts include, as mentioned before, these three. Their function is because they have to protect developing organs, such as your lungs and your liver. So your blood pressure exerts forces on capillaries. But however, these organs, as they're still developing, they're not able to handle the pressure exerted by the full load of the blood flow. So blood must be shunted to allow blood to flow from one place to another. So you have here your ductus venosus in the red square. So this is a shunt that protects your liver. So majority of the blood will enter the ductus venosus and go to the IVC. And this effectively bypasses your portal circulation. So coming from your umbilical vein, most of your blood goes through here, your ductus venosus. And this protects the liver and the portal circulation that's not yet ready for the full amount of blood. It then goes to, from your ductus venosus, it goes to your IVC, and then your right atrium. So next you have your right and left shunts. There are two, your foramen ovale and your ductus arteriosus. But let's first talk about your foramen ovale. So they both serve to protect your lungs. So how? First, the foramen ovale seen here in the yellow box. So your blood is shunted from your right atrium to your left atrium. So this is the route taken by more than a third of your blood. So imagine if the blood flowing from here to your right atrium bypasses your right ventricle and your pulmonary trunk, and therefore your lungs. So it goes straight to the left atrium, to the left ventricle to be pumped to the aorta. So, and it also has a valve here that prevents backflow from your left atrium to your right atrium. Next is your ductus arteriosus, again, functioning to protect your lungs. So this connects your pulmonary trunk here to your aorta. So the flow is from your right atrium. Remember, only a third goes through your foramen ovale, and then the rest goes to your right ventricle, and then the blood will then be pumped to your pulmonary trunk, and instead of going again to your lungs, it goes through your ductus arteriosus straight to the aorta to be pumped to the rest of the body, bypassing the lungs. So the postnatal circulation is mainly achieved by the baby's first breath. So the lungs will expand during the baby's first cry, when they first cry, and then there is a sudden decrease in pulmonary vascular resistance. This allows the blood to flow towards the lungs instead of bypassing it. While on the other hand, there is a loss of blood flow to the placenta, so this doubles systemic vascular resistance. So overall, you have a decreased pulmonary vascular resistance and increased systemic vascular resistance. So these special structures, again, they won't persist in adult life. So these are the remnants of those structures. So your foramen ovale becomes your fossa ovalis. Fossa, because it's now a depression and no longer foramen, which is a hole. Your ductus arteriosus becomes your ligamentum arteriosum, venosus, ligamentum venosum. Umbilical arteries will become your medial umbilical ligament, and your umbilical veins will become your ligamentum teres. So there's also a difference between fetal and adult hemoglobin. So fetal hemoglobin, or HbF, has 2 alpha and 2 gamma chains, and they have a higher affinity for O2 than adult hemoglobin. Of course, you want to bring the oxygen to the baby, so you would gen- generally like be sucking the oxygen across the placenta. And since it has a higher affinity for O2, this will shift your oxygen dissociation curve to the left. And postnatally, of course, fetal hemoglobin will have to be replaced by normal adult hemoglobin. So there is a rapid death of RBCs in the first few weeks of life. Normally, it should be up to 2 weeks. If it's greater than 2 weeks, it's already abnormal. So I've also added here the other factors that shift the curve to the left, and this is the decrease in your CABET, or CO2 concentration, acidity, 2,3 BPG, exercise, and temperature. So now we will be comparing the adult circulation to the fetal circulation, mostly as a review and for attention as well, so you can clearly see how they differ. So again, your arteries for the adult, they carry blood away from the heart. They're usually oxygenated, except for your pulmonary arteries, whilst the fetus has 2 umbilical arteries, which carry the oxygenated blood in wastes to placenta. So in a way, umbilical arteries, in my head, they kind of mirror pulmonary arteries in that they both carry the oxygenated blood. Same goes for veins. They carry blood toward the heart, usually deoxygenated except in pulmonary veins. So for the fetus, you have one umbilical vein carrying oxygenated blood and nutrients from the placenta to the baby. So gas exchange happens at your lungs. For the adult and for the fetus, your lungs are not yet functional, so it happens at your placenta. So the adult has a series circulation, which means it's one way. However, for the fetus, it's parallel because there are a number of tracks which it can take, again afforded by the shunts that are present. The pulmonary circulation in the adult is dilated and constricted in the fetus, and the stroke volume is equal for both ventricles in the adult because there are no shunts, but higher in the right ventricle for fetus because of the presence of intracardiac and extracardiac shunts. So blood volume, your fetus has a higher percent blood volume, 10 to 12%, as opposed to your adult, which has 7 to 8%. And this affords the fetus high diffusion rates in fetal compartments, faster regulation, and restoration of blood volume. Again, for hemoglobin, they differ in that adult hemoglobin has 2 alpha and 2 beta chains, and fetal hemoglobin has 2 alpha and 2 gamma chains with a higher affinity to oxygen. So now we will be discussing the placenta. First, let's begin with the anatomy. This is mainly a review and not as in-depth, just parts that are relevant to our discussion today. So the exchange of oxygen and nutrients, again, they happen in the placenta, more specifically around the terminal villi and the intervillous space. So you have here, this is your fetal compartment, or fetal side, again, as evidenced by the presence of your umbilical cord, and you have your maternal side here. So this is the intervillous space, and these are the terminal villi where maternal blood will flow and exchange of nutrients and oxygen will take place. So a cotyledon is composed of 2 to 3 stem villi and their branching villi here, number 6. And cotyledon is actually what you can see on the maternal side of the placenta, as well as the cut edge of the amnion, while the fetal side looks smooth and shiny, and of course, you can see your very prominent umbilical cord. So the placenta also has a few features that are relevant to be discussed today. So first, it is a gland. So it secretes hormones and it takes over the corpus luteum at 8 to 9 weeks. So you have your human chorionic gonadotropin, or HCG, which stimulates production of your estrogen and progesterone. And then it also secretes estrogen, progesterone, human placental lactogen, and placental IGF-1. It is a multifunctional and disposable organ, so it can act as the lungs, which supply oxygen, the kidney to filter out waste, your GI to deliver nutrients, the immune system to deliver antibodies, and once everything's said and done and the baby has been birthed, it will naturally dispel itself because its purpose has already been fulfilled. So something special about the placenta is that identical twins may or may not share one. So if the egg separates before the formation of the placenta, you will have two placentas. But if the egg separates after the formation of the placenta, you will have one placenta. So the problem is when you have one placenta, or what we call monochorionic. This may lead to twin-to-twin transfusion, which occurs in monozygotic, which is identical twins, again monochorionic, one placenta, and diamniotic, or two sex twins. So as you can see here, you have a twin that's bigger because they receive more blood, more nutrients, and a twin that's smaller and may look anemic once they're birthed. So next is that maternal and fetal blood do not mix. However, some cells may pass, and especially small molecules from the mother to the fetus. So this includes drugs and poisons. This is why you have fetal alcohol syndrome and the transfer of carbon monoxide from smoking from the mother to the fetus. So with that, there are pregnancy safe categories that may help pregnant women with their intake. So you have A to D and X. So A is generally acceptable. These have no evidence of fetal risk. They may be acceptable for B, may B, that's how you remember it. These are animal studies show no risk, and or no human studies are available, or if animal studies showed minor risks and nothing is confirmed in controlled human studies. Next is C, use with caution. C, if benefits outweigh the risks. So animal studies show risks, but human studies are not available, or either both are not available. Second to the last is D, used in life-threatening emergencies with no safer drug available. So there is evidence of fetal risk, but the benefits may outweigh the risk. Lastly, X, of course, is do not use in pregnancy because the risks outweigh any potential benefits, and there may be safer alternatives to take. Fetal cells can transfer to the mother through the placenta. So this is the basis of your non-invasive prenatal testing. So it's a test for chromosomal disorders, and it tests the fetal placental cells in your maternal circulation. So it's quite easily done. You just take a blood sample from the mother, and they can already screen for the following disorders with a 99.9% accuracy. And gender may be determined as well as early as the 9th to 10th week, as opposed to your ultrasound, which may take until the 16th week. Next are the different types of your placenta. So you have first your circumvallate, as seen through this drawing. It's when your chorionic plate, the pink one, is smaller than your basal plate. Then you have your bilobed, as said in the name. There are two equal-sized lobes connected by a thin bridge. Next is your succenturiate lobe, which means there's an additional lobule connected to the main placenta. So succenturiate actually means accessory to an organ. So imagine if your placenta is your organ, you have a little accessory placenta here. It's an additional lobule. Next is your battledore, or your marginal insertion. This is when the placenta is attached to the margin. And your filamentous cord insertion, where the umbilical vessels diverge as they traverse the amnion and chorion before reaching the placenta. So here they've already diverged. Lastly, We're at the last topic for today. It's the congenital anomalies, and the most common birth defect is your congenital heart defect, and it's the leading cause of death in the first year of life. So we have your cyanotic versus your acyanotic congenital heart defects. So first, cyanotic. Don't be overwhelmed. This is easily remembered through 5T's 1 to 5. So because they all start with T and 1 to 5. So first you have your truncus arteriosus. So this is when the vessels, two vessels join to make one. So this is seen in your left ventricle instead of the normal two vessels wherein you have your pulmonary artery and your aorta, they join to make one vessel. And then your transposition of great vessels, where two major vessels are switched. Your tricuspid atresia, 3 for tricuspid, wherein the tricuspid valve is missing or abnormally developed. Next is your tetralogy of Fallot. We will discuss this in the next slide. And your total anomalous pulmonary vascular return. And it's 5 because it consists of 5 words. So for tetralogy of Fallot, it's the most common cause of cyanotic congenital heart defects. So first you have, it's good to think of it first from the ventricle. So you have right ventricular hypertrophy, which is the enlargement of your right ventricle. And then going up, you have your ventricular septal defect, wherein there's a hole between your two ventricles. And then going up again, you have pulmonary stenosis or narrowing of the exit for your right ventricle, and an overriding aorta because blood from both ventricles, left and right, and are allowed to enter into the aorta. So it overrides into your right ventricle. So that's your tetralogy of Fallot. Next and lastly is your acyanotic congenital heart defects. So these are defects including your left to right shunts and your outflow obstructions. So left to right shunts are back leaks of blood from the systemic to the pulmonary circulation, including your atrial septal defect, ventricular septal defect, your patent ductus arteriosus. For your outflow obstruction, you have your pulmonary stenosis, aortic stenosis, and your coarctation of aorta. So that's it. To recap, we discussed cardiac embryology and its development, fetal circulation, the adult and fetal circulation, we compared them, the placenta, its anatomy, variations, and functions, and different congenital anomalies. So remember that the fetus is a separate patient from the mother, therefore must be treated as such. Thank you and good luck.